Us on a Friday morning. All right, you ready, Rach? All right. Good morning, first of all, and thank you so much for joining today's training and today's call. Please note that this is being recorded, so anything said in the chat during this meeting may be part of public record. We encourage you, if you have questions, you can use the Q&A function, and we will use the chat mainly for interactive exercises throughout the training today. Next slide. So today's training is about engaging youth and adults in behavioral health crisis. We're going to talk about evidence-based safety and care planning. So first of all, just really want to welcome you to the training. My name is Jennifer Hodson. I'm a principal consultant with Health Management Associates, or as the top says, HMA. I am out of Raleigh, North Carolina, so we have an office there. HMA is an independent national research and consulting firm, and we focus on improving the administration and delivery of public health, healthcare, and social services programs. I'm also a licensed clinician and have been working in the crisis space for many years, so it's just a privilege to be here with you today. HMA is supporting the Mississippi Department of Mental Health in its efforts to enhance the state's crisis response system, but providing these monthly trainings online for crisis response and provider convenings. So we're really excited to be able to be with you today. So next slide. There are 3 learning objectives that are going to guide the time together. We'll first focus on some foundational concepts of evidence-based safety and care planning. We're then going to differentiate approaches for youth and adults who are in behavioral health crisis. And then at the end, we're going to learn to apply some engagement techniques that can promote collaboration, de-escalation, and stabilization, as well as the core elements of a effective safety and care plan. Next slide. Great job. So learning objectives. So some of what's really important and we want to just focus on today is the core elements of an effective safety and care plan. Next slide. And we'll go ahead to the next one. So we want to start off by learning a little bit about you. So we have a Zoom poll that's going to be coming in. We'd like for you to answer the 5 questions for us to the best of your ability. And then in a couple of slides down, we'll be able to show you how everybody else responded. Your responses will remain anonymous. And you can continue to take this survey while we are continuing to move forward with the content. We just want to just settle in on some definitions because we think it's great to just level set on what different terms and things mean. And when we're talking about behavioral health crisis, this can be any situation that a person's behavior identifies them as being at risk for hurting themselves or others and or may prevent them from being able to care for themselves or function effectively. And in those instances, we may see behavioral health crisis emerge. Part of the work that we do as crisis response workers is safety planning, and this is oftentimes reference to the short-term tools that we might use to help prevent harm and de-escalate and reduce further crises. Researchers have found that plans are better than what we used to call them is contracts. So actually, when we use the word safety planning, we have an opportunity to see improvements in outcomes and lowering of risk. And plans imply partnership with the individual in crisis, which again is what elevates them to have greater meaning and a likelihood of being used. Crisis planning is oftentimes the immediate things that drive our decisions in those acute moments when we're working with individuals. So the immediate actions that we take. And then care planning is a much broader and longer term crisis wellness plan. So after we do the initial crisis planning, we may invite somebody to do care planning, which they would be able to use and apply in future instances to be able to avoid a crisis or an escalation of a crisis. And this is the SAMHSA national guidelines on that slide, and is actually linked to the document. So when you have access to the slides, you can just click on that and go right to that valuable resource. Thank you, Rachel. Next slide. It is really important, as we know, as crisis workers, to be trauma informed. And so people in crisis oftentimes have a history of trauma that can date way back to the formative years or as recent as right before the call for help. And so trauma-informed care, we know if we do certain things, it helps reduce re-traumatization, and it also helps to improve engagement with the individual that we're trying to serve. So how do you apply that? Well, there's several different ways that we can do that, and we're going to unpack some of that in the future slides. But one is to really recognize what those signs of trauma are. We want to ensure all the interventions and the communications that we're doing are empathic, they emphasize patience, and they're really redesigning and designing to reduce any kind of re-traumatization. We want to be a calming presence. We want to establish physical and emotional safety, and we want to offer choices that really help to restore a sense of control for the individual or the family system. And we want to encourage engagement with trusted networks. So for some people in crisis, they've never been able to find those resources and supports they can trust. And part of our responsibility in those moments is to try to help them to identify where those trusted sources can be, whether they're formal or informal. And what SAMHSA has said is that when emergency departments, inpatients, or other crisis-bedded facilities are typically a last resort, when we really work to engage the individual safely in their homes and really work on a safety plan, we can avert and avoid people ending up in facilities where we can help them to heal in place. Next slide. Really want to walk you through some of the potential signs of trauma in youth. The first is emotional. And some of the things that you'll see in youth and adults will differ, and I'm not going to read everything on the slide, but there are some potential clues that can lead us to see that trauma is a part of the person's experience. And with emotional, for example, in youth, you might see fear of separation or extreme mood swings. In adults, you might see exaggerated fears. They might even minimize some of the symptoms, and that can be all part of their emotional sign of a trauma experience. With behavioral, you might see our youth acting things out physically, verbal aggression, social isolation. With adults, again, they might also show some verbal aggressiveness towards authorities. They might struggle with responsibilities, and they might even avoid talking about things that are potential activators for their trauma response. And physiologically, sometimes people talk through their bodies. As we know, in some forms of trauma that have been written about, the body keeps the score. So people might experience or report nightmares, panic attacks, startle responses, stomach aches, headaches. For adults, you can see chronic fatigue, physical symptoms, difficulty with sleeping, panic attacks. So these are some of the other physiological ways trauma may show up in youth and adults. So we'll go to the next slide. And just so you know, Rachel, each of those has an arrow when we get to those. Okay, let's fly in the poll results and let's see where you all rested on some of these questions. Or maybe we're still waiting on the results. Okay, we can keep going forward, Rach. I think we're still waiting on analyzing that. So recognizing and reducing imminent risk is really what safety planning is about. And it isn't the same as long-term therapy. So we really are about looking at short-term plans that help people to increase their stabilization and improve their safety. A lot of how we apply this is looking at warning signs and triggers. So we went through some of the ideas that trauma may show up on previous slides. In safety planning, we may ask about access to means, firearms, medications, and then it's also developing concrete steps for staying safe when we're feeling particularly activated or the urge to act on some of those impulses. Next slide. Here are some of the behavioral health kind of warning signs and triggers that you might see. So if somebody is thinking about self-harm or is having suicidal thoughts or behaviors, particularly for youth, there are verbal, physical, behavioral cues that you would want to pay attention to. Comments may be very explicit, like "I want to die." It could be more indirect. "I don't see the point in living." "I don't want to be here." Some of the physical cues can even be some evidence of self-harm. Behaviorally, maybe giving away things. And for adults, that can look the same or even a little bit different. And this is based on some research, so we just kind of have included some of the ways that most commonly shows up. Same with aggression or threats of violence. Again, verbal, body, and behavioral cues that can somewhat differ between youth and adults in the way they shows up. Things like clenching of the fists or yelling, pacing, throwing objects, using curse words, just different ways to let people know that they're in a state of fight or flight or a stress response, and allows us to sort of figure out, okay, we need to enter into a de-escalation phase in order to have a meaningful movement forward because this person is highly activated. But these are just some of the different ways that it can show up in youth and adults. Next slide. Some may experience severe anxiety or panic attacks. Verbally, they may express not being able to breathe or feelings that they're going to die. Adults may complain of feeling like they're losing control or they're trapped. These are all signs of extreme heightened response to anxiety and a physiological component. For youth, we see a lot of reporting of hyperventilation, trembling, sweating, rapid heart rate. May see some of that in adults, as well as a lot of complaints of dizziness and nausea. So just really wanting to clue in if you hear some of those somatic symptoms, that it could also be a sign of trauma activation, and just wanting to not dismiss any kind of physical symptoms, but to make it a clue in that it could be a part of their trauma response. And then there's disorientation or the presence of psychotic symptoms. It could show up for youth as disorganized speech, talking about things that don't make sense. Adults may also report about feelings of being persecuted or controlled by external forces. They may talk about seeing things that other people don't see, hearing things that other people can't hear. So really important to screen for some of these things so we can then begin to think about next steps and our ability to sort of, even if we use de-escalation techniques, is this individual going to be able to keep themselves safe, or do we need to move to another form of crisis response? So in each of these compartments, we have put some of the verbal cues, the behavioral cues, and the physical cues. And these are not meant to be exhaustive, but they are some of the more common ones that we see. Okay, next slide. Sometimes with trauma, we also see substance use escalation. And, people are oftentimes aware that there's a benefit to use, which is it helps them to calm down. It helps them to feel a little bit less out of control. A lot of times you'll hear them say they use it to cope. So I know that there's been some schools of thought which say not to talk about the positive effects of substances, but we've sort of learned a lot more through research that it is important to understand what role those are playing, especially in the way that people are reacting and responding to trauma. And some of the things you might see if somebody has some impairments might be difficulty walking, unsteady movements, risky behaviors, impaired speech. You may or may not smell or be able to detect it that way, but some of the other symptoms could also be pupil dilation. There could be lots of things that clue us in that we need to also rule out, how much of a substance this individual's taken and just how much we're going to be able to approach the crisis planning that they'll retain and remember. So always important to pay attention to that as well. And then the other is sleep disturbances or fatigue. So this would oftentimes be self-report or report by others. Um, and, and part of when we're if you've ever had an experience of being super tired, for those who may have been cared for a loved one and you're up all night, or a young child, the speech might be a little disorganized. They might have difficulty making sense. Difficulty staying awake, nodding off, may or may not be due to substances, could be due to, real lack of sleep. And then there may be some physical indicators, dark circles, slumped posture of an extended period of difficulty sleeping. Now, some of that can be an alignment with certain symptoms that you might find in certain diagnoses. And some people could just be sustained impact of trauma over time. Okay, next slide. Other warning signs are withdrawal from social interactions. So people who just start to isolate, they don't want to be around other people. It's a protective stance that a lot of times individuals will take. Um, some of it is they just avoid conversations and avoid help because it just feels safer. Reckless or destructive behavior. So again, some people might, be engaging in things that they normally wouldn't do, running away for youth, vandalizing, skipping school. Um, for adults, it could be just self-injurious harm or behavior. So these are just examples. A verbal thing an adult might say is, I don't care what happens, or I want to see if I can push my limits. So this just sense of an endorphin rush, maybe they're trying to get, a dopamine hit, but just you'll see a lot of reckless or destructive behavior sometimes when people are trying to navigate the extremes of a trauma response. Regressive behaviors, so it could be returning to earlier developmental stages. And with younger children, you might see, returning to things that they once mastered. Might even see this in some adolescents as well. They might even have, want to be nurtured and cared for more than they had previously because they're feeling extremely vulnerable. Again, with adults, you'll see some regressive behaviors, things that they might not have normally done that they're back to doing, needing a lot of reassurance, extra sleep, maybe even gravitating towards things that are sensory, um, things that previously helped them, and now they're returning to those things to try to help manage some of the extreme emotional responses that they're feeling. Okay, next slide. It's really important when we're engaging in trauma work that we also don't forget to ask about strengths and being very practical in that approach. And so ask, what have you been done in the past that's helped you to cope? Using, language of capability, we say. So, you already know what works for you. What can we do right now to help you um, to feel more at ease or to relax or to catch some breaths? That might be also helping them to identify people, places, different practices, spiritual, meditation, mindfulness that really help to bring that sense of comfort. And those are all strengths that we need to ask about so that we can incorporate them into that safety planning. It is important in all of this when we're constructing safety plans that we're also being very culturally responsive. So based on a person's identity, their beliefs, their language, their community values, incorporating some of that into the safety planning only ensures that we're creating something with the individual that is likely to be used and have meaning. And on the next slide, I've broken out, we can go ahead to the next. So there is a primary care provider who did some research on what's called the 4 C's of culture. And I have found it to be a great way in a quick period of time to really tap into some of the cultural components that a person might be experiencing when they're in crisis. So the first C is call. What do you call the illness or problem? And this helps us to explore the individual's understanding of the issue, what they believe is happening. Certain words that we may use as professionals, our paraprofessionals might be activating words for the individual. So it's a lot easier to have them name it. And then we use that language as a way to kind of join with them and also help again to de-escalate them so they feel more of that partnership approach. The other C is cause. What do you think caused this to happen? And replace that with, crisis, whatever they're using the words for, why they're reaching out for help. The cause can help us to uncover spiritual, cultural, family beliefs about mental health or crisis in general, or asking for help. So asking what caused it can really help us get an immediate sense of if it's an extreme loss that somebody, then we know that we're going to be activating more grief components of the work that we're doing. Cope, what have you done to cope with the illness or problem? Again, getting at those strengths. So what are some things that they've done in the past that in that moment when they're in fight or flight, their stress response is activated, they might not be thinking about those things. So, okay, well, I mean, maybe breathing has been something that's helped. Maybe taking a walk, maybe sucking on an ice cube, maybe engaging in some sort of prayer or mindfulness, maybe surrounding themselves with people they love. So reminding of the things that cope, and we're learning about those as well. And then concerns, what concerns do they have about treatment or care? And so, that might come with fear, mistrust, barriers that they've experienced in the past. And that allows us as interventionists to sort of maybe break down some of that a little bit and offer that reassurance. There's a lot of stigma that can come with asking for help, or they may have had previous experiences themselves or somebody else that was pretty traumatizing as well. And so we want to understand those so that we can be very mindful of not walking the same path and providing some validation. Again, all of this designed around creating an effective safety plan and helping people to feel heard and seen and to de-escalate. Okay, next. So in this chatterfall that we want to do, so I want you to open up the chat if you can find the little button below to do that. And I want you to think about language, because as we're talking about culture and what people call things, they might come to you with very different words to describe things that we have professional language for. So for example, we might call something depression, but somebody that we're working with might say they feel blue. So if you can do a favor for us as a way to educate ourselves and each other, is just to put some typically mental health terms and what the other terminology is that you've heard used by youth or adults to be synonymous. And so we'll check the chat in a little bit as people start to populate that. Thank you very much. You guys are doing a great job. Absolutely. Great. Okay, next. All right, we're going to move to objective 2, which is just differentiating approaches for youth and adults who may be experiencing behavioral health crises. So while there are core principles of safety and care planning that are similar across age groups, there are different approaches that we have found through best practice that are really helpful for working with youth and adults. Next slide. These are some of the categorical areas that we'll walk through today. We're going to walk through some of them briefly. Again, you'll have the deck as a resource. And each of these particular items will be broken out for you in youth and adults. Next slide. So legal considerations. And I went through last night actually and linked this so you can go right to the statute. But what are the ages that youth can consent and under what circumstances, and who is permitted to be able to provide treatment in those situations. And so, for example, if a person is at least 15 years old, a physician or a psychologist can treat for mental emotional problems caused by or related to alcohol, drugs without a parent or guardian consent, but not for general mental health crises that are not specifically tied. Now, I know there's some active legislation also moving through Mississippi, so we really encourage you to keep an eye on statutes as they're likely to change so that we're always staying up to date on what those legal considerations are. And then obviously adults can legally consent or refuse services under guardianship or in danger to self or others. Developmental needs for youth. Obviously, they're still developing those executive functioning skills, how to emotionally regulate. So the planning that we do with them really has to be concrete and guided, and they might have a lot more questions about the why because they're still building capacity and a knowledge and an understanding about what they're experiencing and how the system works and what they need. Whereas adults tend to really need safety plans that allow them a lot more independence, that are more partnering and really engaging and thinking more long term. A support system is another key differentiator. Oftentimes with youth, they're really dependent on family, school, or caregivers. So we're really looking at those family dynamics and how all these different systems are involved in their care planning. Adults may or may not have a support network, and there may be more emphasis on peers and community services and self-management. So it's really very different when we look at the different individuals that we're serving and the systems that they have access to. Communication, as far as that goes, again, some very different terms might be used. Our youth have different words they use to mean different things, and staying up on that is going to be really important. Youth also respond very well to visuals and simplified concepts. So keeping that in mind. Now, again, there may be some youth who respond more at the adult level, so just being prepared to be flexible, but this is just something to be mindful of. And then adults oftentimes can handle more complex conversations about risk, triggers, recovery, and autonomy. So when we think about educational tools and safety planning, there may be just some different features and facets that come with that. Next. Triggers and risks. Again, we talked about some of the signs of trauma, but different triggers that can send a youth into a mental health crisis and adults. There is some overlap, but there may be also some differences. There's also different crisis planning tools that you can use that are evidence-based for working with youth and adults. One I'll point to towards the bottom is the Wellness Recovery Action Plans, and we have a training that'll be coming up. We'll walk through a little bit more about what that is, and if some of you are already using it in the field, that's great. If some of you are new to it and haven't used it a lot or trying to figure out how we use it collaboratively, we'll be able to talk about that more in a future training. But there are lots of crisis planning tools that are out there that are evidence-based that can really help you walk through what to do in those situations. And then the safety planning process. Again, with youth, it could be identifying trusted adults and school-based supports, and ensuring caregiver safety actions so that they're protecting things that might at that point in time be a risk to somebody's health and well-being, and removing those things from the home. And as adults, again, we definitely want to screen for lethal safety, and then figuring out ways to engage families and other family members and others to secure anything that could be while the crisis is happening, and even after, during that plan of rebuilding, reestablishing, and getting care, that those things are attended to, and then reintroduced when it's a safer environment. Next slide. Care coordination. With kids, you're going to have different systems that you might be coordinating care with, different youth serving agencies, peer supports, providers. And the same with adults. They might have different systems they need help and support with, like housing, determination of transportation, outpatient therapy. So just examples of different ways it might show up in the different systems they may coordinate. Doesn't mean youth won't have to have engagement with care coordination around substance use. Um, Likewise, they might need that as well. And different de-escalation strategies can also happen with youth. We see that they tend to respond to gentle nurturing and reassurance. Um, Not everybody will want the same thing from a crisis response worker, but they also tend to respond pretty well to engagement through trusted youth or even peers. So thinking about building our teams and our care planning so that we can help our youth to be able to engage with people who they might see themselves in and then be able to receive the information a little bit easier. And adults, the same with de-escalation. And we really, with adults, are looking at collaboration and autonomy. And how do we help them feel a sense of mastery over the safety plan? It's something that they can do and it fits for them. And then the plan focus. So emphasizing for youth feeling safe, having trusted relationships and adult supports, and again with adults, self-management and independent coping strategies. But these are really the areas of focus. Next slide. Um, each of our crisis response workers may have different types of strategies. So our mobile crisis teams, when they're working with youth, may be looking for things or doing things a little bit differently than people who might be operating via text or on the phone or in a facility or who are part of the follow-up aftercare process. So we recognize that there are different strategies that might be in play when people are trying to review the safety plan, construct the safety plan, and also make improvements for the safety plan. And again, broke this out for some of the things to be thinking about with youth and adults, just as a starting point for some of the discussion. Okay, next slide. So I want to move to the third objective, which is how do we apply engagement techniques that really promote collaboration, de-escalation, and stabilization? So here's some of the evidence-based interventions that we know of that have been found to be really helpful. The first is motivational interviewing. So I really enjoy this approach because a lot of times interventionist providers, crisis support teams tend to worry that they need to have the answer. And motivational interviewing is really about creating a conversation with somebody to sort of assess and see where they're at, and then help them to think about what it would look like or how to take the next step. So it's really partnering with the person, whether it's a youth or adult, to be able to get to a safety plan that really feels customed and personalized for where that individual is at that point in time, where they're pre-contemplative, contemplative, ready to take action, or where they're dealing with some sort of setbacks and they're trying to figure out how to get back on the path. As some of you know who have been trained in motivational interviewing, OARS is an acronym. Some of the strategies are to ask lots of open-ended questions. So staying away from questions that could potentially lead to one-word answers, just to allow us to really engage and get more of that language and understanding and meaning making from the person that we're serving. Lots of affirmations, reflecting back what you're hearing, and then summarizing towards the end, because sometimes it's helpful to have things repeated back so that the individual feels heard, and they can also correct anything that we may have heard and may have taken in a different direction. There's the Stanley Brown Safety Planning Intervention. This is a real concrete tool to stabilize suicidal crises, and it's really intended to be used after de-escalation. So once you've established de-escalation, then pulling the Stanley Brown Safety Planning Intervention out. Again, the youth wrap and adult wrap, which is the Wellness Recovery Action Plan. It's a very person-centered, evidence-based approach. They look at pre-crisis wellness tools, coping strategies. It is proprietary. It's an evidence-based program, and a lot of the resources are sold on the Copeland Center sites. So if you do engage in RAP, then probably you've gone through some licensing processes, you've purchased some things, and it's become adapted at your system. But we'll talk a little bit more about RAP again in another training. Crisis Prevention Institute offers really amazing de-escalation tactics. They have checklists that you can use to sort of ensure safety. And then it also talks about how we as interventionists can stay calm and help regulate, because we are also humans that are interacting with humans in distress, and the effects of working with lots of people who are in crisis can lead to some secondary trauma. So we really want to acknowledge not only are we developing strategies to help and support others, but how do we keep our teams healthy and safe and able to re-engage in the work. And then there's SAMHSA, which offers trauma-informed care guidelines. And this is phenomenal. This is a 2023 resource, really looking at the work that we're doing, going back to some of the trauma points that we made earlier so that we can minimize re-traumatization. Really looking at just exposure, safety, choice, and collaboration in every contact. Okay, next slide. So back to the objective, we had three things we're going to try to go over. One is, how do we engage to build collaboration? So we want to build an alliance with the youth and the adults that we're working with. We want to preserve as much autonomy as possible, and then really look at motivations for change or for wellness and resources that are accessible. So again, using that motivational interviewing stance, using OARs, finding out from them what's the hardest thing that they're having to navigate right now, reflecting back any feelings that they may have said, to really start to pair thoughts and feelings together. So we're really providing that differentiated reflection back to the individual that helps them to sort of feel heard. If you've ever had the experience where somebody keeps repeating things over and over again or giving more examples, that's usually a sign of needing to slow down and reflect back because they're not sure they're being heard. We may offer limited choices. We know that sometimes if we give a whole booklet of resources, that can be way too much for somebody in crisis. So can you provide at least 2 to 3 really safe options that you believe would support that person's agency, and help them to de-escalate and avoid future crises? Sometimes it's little mindfulness strategies that have the biggest impact, like teaching a breathing technique or a grounding technique where you're having somebody focus on what they see, hear, smell, taste, touch in order to orient them to the present. And then once you get them fully engaged in the present, then you can move toward developing care planning where there's shared decision making and they're not operating in a response state. You can use rap language, where you really look at like what usually helps you when this starts, so we can rebuild back in some of those coping strategies and tools. So rap is really known for that and building that into the safety plan. And then explain your role and your limits and transparency. So state what you'll do, what you can promise, what you can't promise, and who else might be involved. So if somebody is engaging in behaviors that the mental health law requires that you act in accordance, then explaining that, or talk about harming somebody else, that there are certain things that you'll need to do with that information. And it's really important that we explain that to them. But reading each situation for safety is also really important. So if you feel like you need a co-responder there to be able to do that, then being able to navigate that as well. All right, next. Some techniques to de-escalate. So we want to reduce physiological and emotional agitation. so that the person can collaborate in safety planning. When we're really activated and in our stress response state, it's hard to think through going to a doctor's appointment next week or even to get through the next few moments. So once we can get somebody who's de-escalated, then we can start to open up options and opportunities and having them think beyond the moment that they're in. So some techniques, again, is to really have that calm presence and really regulating your tone. So that steady voice, keeping a respectful distance. Um, if you have a team of people there, have maybe one person to be the lead voice so that it's not so many people kind of talking at, but you've got one person really taking the lead. You want to reduce stimulation and offer grounding. We talked about 5, 4, 3, 2, 1, the sensory exercise, but also thinking about if there's emergency lights that are flashing, if you're in a place where there's neighbors or others that are observing, can we move to a place that feels a little more private and respectful and safe to that individual? Can we use short reflective statements? Like, it looks like you're feeling overwhelmed and need some space. So I had somebody I was working with just yesterday where they needed to go out and take a smoke break, and that was helpful to them. So just having that opportunity to take that space, that's what they did to be able to regulate. Then they came back in and they were able to re-engage. Um, we want to set clear, respectful limits when safety is a concern. So if somebody wants to go out and take a break, we might have to have somebody go with them because at that moment it may not be safe to have them go out by themselves, but explaining that. Explaining, I'd like to go with you. I want you to be able to have this opportunity to just take a break. But I also want to make sure that you're safe. Can we just sit together? All right, next. The other is to help people to stabilize. So this is creating concrete person-centered plans that really help to de-escalate and lower that short-term risk, and then also help them to connect to support systems that they're going to need after you move away from your limited role. So some of these techniques, obviously with things like a Stanley Brown safety plan, which is a certain type of evidence-based tool, once everybody's calmer, you can really look at adding things into the safety plan, like what are some warning signs that things are starting to get harder and more difficult? My sleeping is reduced, I stop communicating with people about what I need. I stop taking care of myself, my drug use goes up, my food intake goes down, I stop going to my therapist. So being able to put things into a plan that are warning signs are a great thing to do, but we do that once we're able to get people de-escalated and then we move to that. Um, Again, coping strategies, what has helped before is really important. That gets at some of the cultural components as well, so that we can make sure we're weaving those in. Different wellness tools that you can add to the person's safety plan, things they may have thought of or things they haven't, like an app that can help them, do the diaphragmatic breathing with a visualization, or an app that has a variety of choices that they can engage in when they're feeling overstimulated, or they need some support, or reminding them about resources like 988, or other support systems and support groups in the community or peer supports. Really concrete, plans where, you kind of remove things, like harmful things that they have talked about where the intent is to hurt themselves, or potentially others. So medication, firearms, and then making sure we're carefully documenting what the recommendations were in that. You might have a family member that might pull you aside and say, listen, we have a gun in the house. They haven't talked about that. But do you think it'd be a good idea if we remove that from the home for the time being? So sometimes families will help, participate in that, letting you know that there may be some things in the home, and you can kind of help create some of the plan with those people that are there as well. And then you want to at least write the plan down for people, give them copies. You'll document the plan on your end and then confirm for them what those next steps are. And you might have to repeat things a couple of times because when an individual's in crisis, capacity may or may not be there to remember. And the same goes for any loved ones or others who may be present and that who will be walking with them through the next steps. And some of you in your roles may also have follow-up responsibilities. So being able to call back to see how the plan is doing, if it's working, if it's not, what modifications might be needed. Were they able to make it to the appointments? And just having those check-ins. And that's all part of stabilization. There are some questions that are really important for building trust because, as we've talked about quite a bit throughout this, that we call it a therapeutic alliance, but that creation of that trusted relationship is what makes the difference between creating an effective safety plan and not. And so, how we show up, how we present, how we self-care, how we attend to the cultural pieces that might be present for that individual, um, how we're able to modify what we're doing for a youth versus an adult, how do we recognize the other people that are around are all part of building that trusting relationship. With youth specifically, there are some questions. Sometimes we just need ideas, things that we can ask. So with youth, what's been the hardest thing for you to deal with lately? I've oftentimes, when I've worked with people, their thoughts are racing so much and they're just feeling so out of control internally that just being able to think is hard. So you might have to go back to de-escalation. Um, but then once they're able to do that, unpack some more of the situation and the story. Who do you usually talk to when stuff feels really tough? If you can change one thing about how you're feeling right now, what would it be? Can you tell me about a time that you felt safe or relaxed recently? Is there somebody like a friend or family member, a teacher that you trust to help you? Again, all of these things are strategies for being able to build out that treatment plan. And writing it down also, when an individual's in crisis, oftentimes they'll feel so alone and they don't think about or realize until it's written down all of the different ways that they can be cared for or that there are people out there who will, whether it's their professional systems or family systems. Okay, next slide. Here's some trust building questions for adults. Again, can you share with me what's most important for you right now? What's worked for you in the past when you face tough times? Who are the people in your life that you feel safe turning to? What do you need most from me in this moment? Okay, next slide. So in the Chatterfall, I want to go back to it. You did such a great job putting in some synonymous words with mood terms that we typically use professionally that you might hear out in the field. But what are some other ways, if you can put in that you found useful to connecting with youth and adults in crisis? Some strategies or ways that you have found that work, that help de-escalate and help people move through to a safety plan a little more effectively. So would love to learn to tap into some of your expertise as well, and feel free to populate that in the chat so everybody can learn from you and with you. Okay, next slide. All right, this is the last objective that we'll cover today, and these are the core elements of an effective safety and care plan. So next slide. So some core elements of a safety plan, and you've heard me mention this already, is just putting down the warning signs. So anything that a person identifies that could be prodromal, like thoughts, feelings, behaviors, situation that indicate to them a crisis event might be starting. There may be examples like feeling hopeless, withdrawing, changes in sleep, appetite. So these are all things that we would want to put on the list. Some coping strategies, we want to make sure that's present in the safety plan, things that they can do on their own or with others to help calm themselves down. Um, Social contacts for distraction. So do they have people or places that they can go to or call that can help them to break the loop? If they're stuck in a thinking process that is just making them feel worse, are there people that are in their life who can help them to sort of alter that enough to where they can really see things a little bit bigger than they might be seeing them in that moment? I love Let's Breathe. Humor's good. Was looking at your chat. Okay, the next slide. People to ask for help. So, it is really important in that plan that if they do have names of individuals, even if they're people who are not of biorelation, but by association. So anybody they can connect with, if it's somebody else who may be in their community, maybe it's a vendor, maybe it's I had a client once who just really connected with a barista at a Starbucks. And so they would go in and not necessarily share their day, but they knew they would always get a smile. And that helped just give them a little bit of a lift. So sometimes it can be going to a familiar place, talking to somebody, visiting a place of worship could be something for somebody. So we just want to build that in. Also making sure they're aware of crisis line numbers and resources in their community, could be warm lines for youth, mobile crisis teams. I like to take the opportunity to explain what these are because there could be some stigma or misunderstanding about what the services are and what they offer, and something that nobody had realized was even within reach for them. So being able to sort of take the opportunity to say, have you ever worked with a peer support specialist before? And here's some of the ways that they can be extraordinarily helpful. We also want to make sure that the environment remains safe. So that's the other core element of the safety plan. Are there any things in the vicinity of that individual that could put them at further risk? And for youth, that would involve caregiver participation. So they're also aware. Next slide. This is just an example, and it's small in this, but you can blow it up when you have access to the deck, and that's the Stanley Brown Safety Plan. So you can just see the different steps that it walks you through. Sometimes when you're being present with somebody, it's hard to like think through all of the steps because you want them to feel your empathy and you want them to feel your attention. And having them do a tool with you can be a really great way to make sure that you're getting all of those different areas covered. So that's just an example of one. The next slide is an example of one you can do with youth. And again, this is a safety plan that reminds them of their strengths, of who they can call for help, where they can go, activities to help take their mind off of things. And you can use clear, plain words because that's oftentimes much more helpful for youth than our professional jargon. You can make it colorful. You can have the youth use different color pens for different things. And role playing is really powerful for youth too. So if they're like, I don't even know how I would let my friends know I'm struggling, well, let's role play that out. And I oftentimes would have them be the friend, so I can see what they believe the challenge might be and try to help them navigate that. All right, next slide. There's some differences in safety planning. Obviously, with MCERT teams, the planning would begin on site. With 988 staff, it might begin more with verbal planning and text templates during calls. With crisis stabilization units, it might be a plan during admission and then revised at discharge. Community and caregiving partners, they're essential to like reviewing it, updating it, and then also reinforcing it. All right, so we have one last set of polls that we want to do just to get a sense of how comfortable you feel. Not that this training would have provided you with all of the skills of motivational interviewing, but just to get a sense so that we know maybe how to incorporate some things into future trainings. So if you can just take a moment and go through these questions, there's just 5. I really appreciate some of the things that you have put in the chat. Very helpful. Okay, very good. You're doing a great job. And Rachel, I don't know, do we have yet the responses from the first one? We can fly those in too. All right, while Rachel's doing that, you can kind of finish up responding to some of these questions. I see some of you are still working on that. Okay, let's go on to the next slide. And if you're still working on it, that's okay. This will not stop you. Um, what do you think, Rach? Do you think we're going to be able to get them in? Or is it being stubborn? Oh, you can? Okay. One of the things that we really want to draw your attention to is that all of these recorded trainings will be housed at the training library on the DMH website. So that is also linked to this slide. So you can revisit that. They're pretty good at getting trainings up fairly quickly. So you can refer back to them and utilize them as you might need in the future. And we're going to continue to populate this training library through June 2026. And here's some of the topics. You may have attended some of these trainings already, and we have some that are coming up. So certainly if there's anything that you're interested in learning more about that you don't see on this list, please don't hesitate to let us know. We'll see if we can incorporate it in some of the trainings that we have yet to develop, if it's possible to do. There's so many important topics to cover, but we're really invested in hearing some of the concerns and the questions that you're having in the field that we can expand on in the trainings. All right, Rach, what's the verdict? Oh, here we go. So, how confident do you feel in facilitating a safety plan through a crisis? We have somewhat to very confident. We have a few that's never done it and not. So hopefully today gives you a few more ideas and resources to move forward with, but that's great. That is great. Do you use different approaches for youth and safety planning versus adults? Yes, a lot of you have been very skillful in doing that, so that's great. And if you haven't had a lot of opportunity working with youth, that's another area where, as professionals, we continue to develop across our careers. In your experience, what's the biggest barrier to safety planning? Family dynamics. Oh, that's very interesting. So navigating those in the field or even counting on them as part of a safety planning when sometimes family members themselves might still need their own help and support. Lack of engagement is in the next, and then time constraints. So, and access to tools templates. So there's still some need to make sure we're giving enough of resources when you're out in the field that you feel comfortable and confident that you can walk somebody through a safety plan. That's good. All right. Next is, do you believe youth can meaningful participate in their own? Yes, always, sometimes, and then it depends. So, and I think it's fair. Like sometimes, even with an adult, the ability to participate in the safety planning might be difficult, particularly if they're evidencing signs of altered state because of substances or experience of psychosis. So it really does depend. And an adult client refuses to complete a safety plan. What's your next move? Ooh, I really love where you're at with that. So really explore what's making them uncomfortable. Absolutely. I think people sometimes have different reasons for being hesitant, and we can break down some of the myths or concerns right there and then revisit. We want to definitely be respecting their choice documenting, which is really important. That was the next thing that some of you said. And we might need to go to a supervisor to say, listen, I'm continuously having this issue, and see if it's something that we're doing in the way that we're presenting it. Excellent. Thank you for sharing that, Rach. I was glad we were able to get that up before you left. All right. Well, make sure you follow us on social media. So there's Facebook, there's YouTube, there's Instagram, and the whole point of doing this is to get us interconnected and working together as a cohesive system. So thank you for being a part of that today, and we really wish you the very best. Hope you have a great rest of your day. And again, your feedback is always welcome. Thank you.